Hi everyone, this is Sarah Turchak, and today I would like to talk to you about the new drug apixaban, Eliquis. Through this short presentation, we will go through its indications, mechanism of action, and its comparison to its competitor warfarin. Afterwards, we will also briefly compare its TV commercial claims against peer-reviewed data. Here's a little bit of backstory. Apixaban, Eliquis, was FDA approved in 2012 and is one of 4 oral anticoagulants called direct activated factor X inhibitors currently available in the market. It belongs to this novel class along with rivaroxaban, edoxaban, and betrixaban that were FDA approved in 2011, 2015, and 2017 respectively. Compare this to the fact that its competitor warfarin obtained FDA approval way back in 1997, though it has been used in human treatment as early as 1955 as treatment for President Eisenhower's MI. Therefore, we can say that Eliquis belongs to an emerging class of oral anticoagulants. So, what is Eliquis used for? Well, Eliquis is approved for treatment of DVT and PE. It is also approved in their prevention in certain situations such as DVT after knee arthroplasty, DVT after total hip replacement, stroke and embolism secondary to non-valvular AFib, recurrent DVT, and recurrent PE. Currently, there are no off-label indications for apixaban. So how does Eliquis work? In order to explain how Eliquis inhibits coagulation, we need to briefly review what entails the coagulation cascade that ultimately forms the stable clot made of fibrin threads. Because the coagulation cascade consists of a series of complex chain reactions that is beyond the scope of this report, we will only discuss parts of the cascade relating to activated factor X, also known as factor Xa. Now, how does a blood clot form? Platelets and clotting factors work together to stop blood loss at the injury site. After the local vasoconstriction that occurs at blood vessel injury, platelets from the initial plug to prevent any more blood loss. If this platelet plug is not good enough in preventing blood loss, for example in the case of a large injury, the inactive clotting factors circulating in the blood are activated in a stepwise fashion in what's called as the coagulation cascade. Let's take a look at the right side of this diagram. See at the bottom right where it says final common pathway? Towards the end of the coagulation cascade, activated factor X, which we'll call factor Xa, catalyzes the conversion of prothrombin, factor II, into thrombin, factor IIa. In turn, thrombin catalyzes the conversion of fibrinogen, factor I, into long strands of fibrin, factor Ia. These fibrin threads act as glue that traps other platelets and red blood cells, which makes the plug more stable in achieving hemostasis than what the platelet plug alone could do. So going back to our question, how does Eliquis work? Eliquis inhibits factor Xa by binding to its active site both in freely circulating and clot-bound factor Xa. This inhibition results in decreased thrombin generation and decreased fibrin clot formation. When Eliquis inhibits clot-bound factor Xa, it also inhibits prothrombinase, a complex of prothrombin and factors Xa and 5a. Since prothrombinase acts as the enzyme that converts prothrombin into thrombin, its inhibition means that fibrinogen will not be activated into fibrin. Now compare this to how warfarin works. Warfarin's anticoagulant effect is through inhibiting the action of vitamin K. Vitamin K is needed for the liver to make clotting factors 2, 7, 9, and 10. Therefore, by antagonizing vitamin K, the synthesis of these 4 clotting factors is decreased, inhibiting multiple steps of the coagulation cascade. This ultimately diminishes the likelihood for a fibrin clot to form. So, because Eliquis is more selective and less encompassing in its target on the coagulation cascade than warfarin is, the risk for adverse bleeding is reduced when people use Eliquis. Although this could be a very good thing for those who take Eliquis, the novel drug has its limitations. To this day, there is no FDA-approved reversal agent for factor Xa inhibitors. This can be problematic in cases of hemorrhagic emergencies. Contrast this to the availability of vitamin K as an antidote for the vitamin K antagonist warfarin. Fortunately, there is, under development, a factor Xa inhibitor reversal agent called andexanet alpha that has shown favorable effects in phase 3 trials. Additionally, while oral warfarin has a half-life of approximately 1 week, oral Eliquis has a shorter half-life of about 7 to 16 hours. This may provide some assurance that serum drug levels will decrease fast when Eliquis is discontinued, provided the patient has a normal kidney function. Conversely, its short half-life can intensify the potential pro-clotting effect of non-compliance. So, what do its TV commercials say Eliquis can do, and how do these claims compare to peer-reviewed data? As of today, 14 commercials advertising for Eliquis are currently available for the public to view on the internet for free through the iSpot.tv website, a database of nationally airing TV commercials. Each of these commercials features a paid commercial actor or actress, most of whom seem to be at least middle-aged, encouraging viewers to talk to their doctor about Eliquis. 10 of these commercials have an actor or actress who has non-valvular AFib and is aware of his or her increased risk for stroke. The other 4 feature an actor or actress having just been discharged from the hospital on warfarin after a DVT, worried about the event reoccurring. All of the actors and actresses portray their desire to do their best in continuing their previous lifestyles, whether it be in cycling, hiking, skiing, jogging, or kayaking, among other things, and so they choose Eliquis. This is because, in the case of the non-valvular AFib commercials, the actor or actress claims that Eliquis reduced risk of stroke better than warfarin and produced less major bleeding than warfarin. And in the case of the DVT commercials, the actor or actress claims that Eliquis has been proven effective in treating PE DVT blood clots and produced significantly less major bleeding than the standard treatment of Lovenox bridged to warfarin. Additionally, some of them, from both groups, mention the advantage of the fact that there is no routine blood testing required with Eliquis. Eliquis was FDA approved based on the favorable results of 2 randomized double-blinded phase 3 clinical trials, called Averroes and Aristotle. Furthermore, the randomized double-blinded Amplify trial was the basis of the commercial's claim that Eliquis has been proven effective in treating PE DVT blood clots and produced significantly less major bleeding than the standard treatment of Lovenox bridged to warfarin. However, because the Averroes trial focused on Eliquis's comparison to aspirin in preventing stroke in patients with non-valvular AFib, we will only briefly talk about the Aristotle and the Amplify trials. These 2 trials focus on Eliquis's comparison to warfarin. Both manufacturers-sponsored Aristotle and Amplify trials were published in peer-reviewed journals and support the following claims mentioned in the commercials. Claim 1 of 2. With Eliquis, there is reduced risk of stroke better than warfarin, plus there is less major bleeding than warfarin. The Aristotle trial compared the efficacy and safety of apixaban 5 mg taken PO twice daily to warfarin with target INR 2 to 3 based dosing in patients with non-valvular AFib with at least 1 additional risk factor for stroke. There were 18,000 subjects with a median age of 70 years. The median duration of follow-up was 1.8 years. And the authors found that Eliquis was indeed superior to warfarin in decreasing the risk of stroke or systemic embolism. This is in comparison to 1.27% per year for Eliquis versus 1.60% per year for warfarin. Additionally, patients who received Eliquis showed lower major bleeding rates. Claim number 2. Eliquis has been effective in treating PEDVT while producing significantly less major bleeding than the standard treatment of Lovenox bridged to warfarin. The Amplify trial compared the efficacy and safety of oral Eliquis, 10 mg twice daily for 7 days, then 5 mg twice daily for 6 months, to conventional therapy of sub-Q Lovenox followed by warfarin with goal INR 2 to 3 for 6 months. There was a follow-up 30 days after the end of the treatment period. The median age of the Eliquis subjects was 57 years, while the median age of the conventional subjects was 56 years. The results showed that 2.3% of the apixaban subjects experienced recurrent symptomatic PEDVT in comparison to 2.7% of the conventional subjects. Additionally, 0.6% of Eliquis subjects, in comparison to 1.8% of conventional subjects, experienced major bleeding. And so we've discussed what Eliquis is used for, its mechanism of action, and its comparison to warfarin. We've also briefly gone over the data that support its manufacturer claims. So do I think that the switch from warfarin to the newer drug Eliquis is worth it? With no routine INR required, I think Eliquis would be worth it for a good quality of life. What about you? What do you think? Feel free to comment on the section below, and thanks for listening.